I would like to now talk about the actual explantation surgery and how we perform that, or the idea behind it, what M block is, if we use drains, and all sorts of things like that. The surgery itself we do in a fully accredited ambulatory surgery center and have board certified anesthesiologist. The surgery itself is between 3 to 4 hours, depending if we just do the explant alone or if we do an explant with a breast lift simultaneously. This is typically performed as an outpatient, so you go home the same day. And a lot of people ask, do you use drains? And yes, I do. I will put one drain on each side. I think it's safer. It helps evacuate some of the inflammatory fluid and gets the tissue to kind of heal and seal a little bit more quickly. We will prescribe pain medications as well as muscle relaxants because of the fact that the muscle is usually attached to the capsule, and inadvertently we will have some muscle damage and muscle irritation, and so the muscle relaxants can make a nice difference with that as well. Another option that we can offer is a long-lasting, sustained local anesthetic. The particular brand is called Exparel, but this is a liposomal or a fatty encased local anesthetic that will last up to 72 hours postoperatively, which will get you over the major hump of the discomfort. I will usually use an inframammary approach or an incision underneath the breast, as this gives me the best access above, below, and on each side of the implant. We try to remove these en bloc, and what en bloc means is to take the entire scar capsule with the implant still housed internally and get this out as one complete unit. This is usually a little easier to perform when the implant is on top of the muscle and just under the breast tissue. When the implant is under the muscle, it tends to be adherent to the muscle above and to the ribs and the intercostal or between the rib muscles beneath. It's very adherent in this area, and if there are multiple small openings into the capsule, I have developed a technique where I can then make a controlled capsulotomy or an opening in that scar capsule right underneath the skin incision and pull the implant out without any spillage or contamination internally. Once that implant is out, we can then get the rest of the capsule out, typically in one piece, without pulling and stretching the tissue, trying to retract around the bulk and the volume of the implant. If somebody would subsequently be a good candidate for a mastopexy, if their breast tissue is a little bit more ptotic or droopy, I highly suggest doing this at the same surgery. There are certain things that I can do with the implant and capsule out by tacking your breast tissue up to the ribs and the muscles between the ribs to help fill that gap or the void in the upper and central portion of the breast where the implant used to reside. And this tends to give a little bit more fullness. There are some other techniques that I have found by putting some sutures into the breast tissue itself in a middle layer that helps further shape the existing breast tissue and then tightening the skin as well. So it's almost like a three-layered mastopexy that tends to give better shape and better position to the existing breast tissue. Of course, after everything's healed and you're getting well again, we can always go back in 9 months to a year and do autologous fat grafting, or take fat from somewhere else on your body and help give a little bit more fullness into the breast itself. Now, a lot of ladies talk about using suctioning in the recovery time and something called fluffing. I think what actually happens is the ribs from the implant being there get kind of pushed or bowed in. And we see this quite frequently, that when we remove the implant and the capsule, the ribs actually have an indentation. And that's from the external pressure. Without that pressure being there, with the implants removed and taking big deep breaths over the next several months, the internal aspect of the pressure intrathoracically or around your lungs continues to push those ribs back out. So it's a very slow process, but that little bit of pressure, I think, remolds those ribs So instead of being the convex, they now become more concave. And so we start to see a little bit better volume to the chest and the breast. And I think that is what women talk about when they hear about fluffing. It's actually the ribs remolding to their native position.